All right, well, thank you all for coming out tonight to learn more about OCT angiography. I'm so excited to share my enthusiasm for this technology with you. So what I'd like to do is just start off with talking a little bit about the technology, how the scans are obtained. I'm going to show you some normative scans so that when Rob, Nate, and I go into the specific disease entities, you'll understand what normal looks like, so you'll be able to identify abnormal, okay? So moving forward, what is OCTA? We're going to start off with the basic question. We all know that OCTA is allowing us now to visualize retinal and choroidal vasculature non-invasively. Well, who cares, right? Why we've been practicing for 30 years without it, however many years, hundreds of years without it. Why do we need it? How many AMD patients do we see every day where we're running B scans, spectral domain B scans, and we just want more information? They're tricky, right? We're not sure what's going on. This technology is going to give us that, okay? It's going to give us that extra little bit of information that's going to help us to make better decisions, okay? There's going to be patients that we can actually hold on to in our practices longer that we were referring out, and there might be patients that really don't need to be referred out, okay? Or do need to be referred out, and vice versa, you guys get me. What about diabetes, right? I think that Craig talked before about how this OCTA technology is showing us identifying evidence of disease so much earlier than on fundoscopic examination. This is going to allow us to take better care of our patients, right? We're going to have better communication with the internist. We're going to have better communication with the patient. These patients might think they're doing phenomenally well, and the OCTA is giving us information that we didn't see before, okay? So this is giving us just awesome, awesome information. My students will say to me, Dr. Rodman, I want the technology because I want to be the person on the block that has the coolest, greatest toys, right? And I don't really care why you want it, but I certainly feel like we're doing a disservice by not having it, okay? It's really been the best addition to my practice that I've had in a long time. All right, so what do you get with OCTA? How does it differ from a spectral domain OCT? With our spectral domain OCT, we're getting a structural B scan, okay? We're imaging the retina at one moment in time. If I were to image myself now, and myself in 10 minutes, and myself in 15 minutes, that image is going to look identical because it's a structural piece of information, okay? SD-OCT is awesome for looking at specific entities, which we're going to talk about, but it's not awesome at looking at everything. OCTA is going to add that second piece. It's going to show us the vascular integrity. It's going to show us the microvasculature, okay? It's imaging red blood cells within a blood vessel, all right? So anything that's moving might change when you image. So that's why I wrote up there it's a time-dependent image. If I were to image myself now and in 10 minutes and 15 minutes, it might look a little bit different if there's abnormal vasculature, okay? So you can see on the picture there what the two different printouts are going to look like. We have the angiography printout on top, and we have the B scan or the structural printout on the bottom. And really, ideally, what we're looking for here is that we look at these images hand in hand, okay? Because again, each one is optimal at imaging something, okay? And when you get the printout, you're going to see the structural image and our vascular pattern, if you want to say, or vascular integrity, whatever you want to call it, side by side, okay? All right, so here's the slide showing you what each of these technologies optimally image, okay? So the structural OCT, the spectral domain OCT is good for any elevations or depressions in tissue. So things like drusen, things like pockets of fluid, all right, exudates, anything like that. The OCTA is going to show us, I like to think of it as too much blood or not enough blood, okay? So if you have too much blood, like a CNV, awesome. What about not enough blood? Microvascular disease, diabetes, vascular occlusions, okay? So again, side by side, these technologies make a perfect image or a perfect page of information. So how does OCTA work? I'm going to talk you through this really quickly. I don't want to go into the really hardcore technology, but for all of you that have had the machine, you sit the patient down. It's going to ask you to take 2 consecutive images rapidly, okay? So that's what you can see on the side there. I have 2 B scans, okay? It's really, really important that you get 2 very high quality B scans. Why? Because all the different stuff that's going to be made to produce the angiogram comes from these B scans. So if you don't get a good quality, you probably want to start over, okay? Once you have your 2 B scans, the machine is going to look at any difference in signal between the 2. We can't see it to the naked eye, but the machine can. And the machine is going to show us, if you look on the slide on the right, the pixelation map. The little red dots, that's the flow. That's every difference in signal that the machine has found between the 2 images, okay? All right, so the angiography or en-face cuts, just to recall from optometry school, en-face is like doing a C-section through your B scan, okay? So essentially, if you look at the retinal anatomy, That correlates with your B-scan, right? You have cuts that correlate with retinal anatomy. The OCTA is now going to give us the vascular pattern to each area of the retinal anatomy, okay? So you take your first cut, your first en face, through the superficial retina. The superficial retina is ILM to IPL. It's fed by the superficial capillary plexus, okay? So that first en face that you see on the top there is our vascular pattern to the superficial capillary plexus. The area in the center is black because if you were to cut through your B-scan, you're going to hit your fovea, right? You're going to hit the pit in the fovea. That area doesn't have blood supply. It's black, okay? As you go further down, more posterior, you're hitting your deep retina, which is your INL to your OPL. Same thing, you're still going to hit your foveolae vascular zone, so you're still going to have a dark spot with a lot of nice perfusion around it. As you go more posterior, you're at the level surrounding the RPE. Very important that the RPE in normal patients is black, okay? RPE is avascular. Remember that because as you go through scans, if you see vascularity in that plexus, there's a problem, okay? And then as you go more posterior to the choroid, that's a very highly vascularized tissue, so it's completely white. It's spongy like that, okay? So this we have posted in our clinic at Nova, so the students can always remember what normal looks like. Because again, if you don't remember this slide, Nate's presentation especially, because I think Rob's doing glaucoma, but it will make no sense to you. You have to remember normal to understand what abnormal looks like. All right, so I'm going to jump into my piece of the presentation, which is I'm going to focus on outer retinal pathology. That's going to include CNVM, the 4 types, CSR, and PED. Even though it looks like a lot of information, I tried to sum it up the best I can. So I'm going to spend a little bit of time talking about the pathophysiology of each of these, because if you don't understand the pathophysiology, you can tell I teach, you're not going to understand how to interpret the angiogram, okay? So let's start off with a type 1. I want you to pay attention to the schematic on the bottom, the picture of the retinal anatomy. A type 1 CNV originates in the choroid, okay? It'll course up. You can see the yellow is the abnormal vasculature. It's going to course up through Bruch's membrane, but it's going to stop below the level of the RPE, okay? That's crucial. So an occult CNV is a sub-RPE membrane. Why does that matter? Why am I putting so much emphasis on it? Because when we interpret angio, that's critical. So when you look at the B-scan, you can certainly see there's a hyperreflective area underneath the level of the RPE. So we could pretty much see just on this B-scan that there's something going on and it looks occult, right? It looks like it's below the level of the RPE. What if we're not sure? We run our angio. So I always start off at the level of the choriocapillaris. I'm looking at outer retinal disease, so I want to start posterior. So I look at the choroid and I can see that there's an abnormal little lacy network there, okay? The question is, does my abnormal network course up through the outer retina? Remember, outer retina is RPE and the area around it. So if that vessel went anterior through the RPE, I would no longer be at an occult, okay? So for an occult membrane, it has to stay low. That's how I like to think about it. So here's a color-coded kind of schematic of what an occult CNV looks like, the characteristics of an occult CNV. The first thing is notice how large the vascular pattern is. They're messy and they're irregular. The second thing is they don't usually affect the FAZ. They usually border the FAZ, okay? And you can see on the bottom there I showed us two different B scans of 2 different types of occult membranes, but they both have different patterns, but they're large and irregular. Here's an example of a patient, and when you look at their fundus image, it's not clear what's going on. You can see there's bleeding, there's mottling, there's drusen. Can't tell without doing a B scan first what's going on. We look at the B scan and you can clearly see that there's something going on below the level of the RPE, okay? So we can probably make the determination that this is an occult CNV. We send the patient for a fluorescein. If you remember, occult membranes don't image very well with fluorescein. You need an ICG. So the fluorescein there is messy, it doesn't really show me very much. So this is a situation where the OCTA is very helpful, okay? The level of the choroid, we start off, you can see there's an abnormal vascular network. We look up at the outer retina, guess what? It's clean. What does that mean? It means that the membrane is low, it didn't permeate through the level of the RPE, and we can be certain, or we can be more confident in our diagnosis that this is an occult CNV. Let's go into the classic now. Okay, so in the classic, we're going to look at the picture again on the bottom left. Our vessels originate again at the level of the choroid. The vessels come up through Bruch's. But in this particular situation, they actually go up through the RPE, okay? And again, that's really important because that's how you're going to differentiate between the two types of membranes. When you look at the angiogram, again, we're going to start at the level of the choroid. You can see there's abnormal vasculature there. Then we're going to look at the level of the outer retina. It's clear that the hyperfluorescence has continued through the level of the outer retina, indicating that that abnormal vasculature has come up through the RPE. And in fact, in this case, the vessels have even gone up through deep retina. Okay? And they can't get to deep retina if they haven't gone through the RPE. So if you remember, I showed you before what the occult looks like. Look how pretty the classics are. So the classics look like bicycle spokes or sea fans, and they're very clean and confluent and concentric, okay? And they usually border, they actually involve the fovea vascular zone. And if you look on the bottom, there's 4 different B scans. There are 4 different types of classic membranes, and you can see how the shapes are very heterogeneous. Okay, but they're much prettier and cleaner than the occult ones. And you can begin to identify them just based on their characteristics. Here's a patient that was 48. He came in complaining of a dark spot in his right eye. We do a B scan, and you can clearly see on the B scan that the hyperreflective area is above the level of the RP. So again, this is a pretty easy B scan to interpret. I would say it looks classic. What if you want to confirm? What if you want to be sure? We look at the level of the choriocapillaris. We have an abnormal, messy area there. And then when we go into deep retina, you can see that, outer retina, you can see that it has gone up anterior through the RPE. I'm going to skip to type 4 and then go back to type 3 just because it flows better. So type 4 is a mixed CNV, right? Type 4 is a mixed bag. You have a little bit of occult, you have a little bit of classic. When you look at my picture, that white area is the RPE. You can see there's one high flow lesion underneath the level of the RPE, that would be our occult. And then you can see the second lesion above the level of the RPE, that would be our classic, okay? So when you look at this on angio, we're going to start to, the image all the way to my right. I think it's all the way to your right. You can see that there's a big messy lesion there, okay? Just by looking at that, nobody could tell you what type of CNV that is. What happens, though, if you were to take your slab and you started to move it little by little more anterior, okay? We're not going choriocapillaris to deep retina. What if we just went little by little, we're coursing up? So the picture in the middle, you can begin to identify that there's 2 lesions. So you can begin to see that as we're getting closer now to the outer retina, the 2 membranes are becoming more apparent. Look what happens when I get to outer retina. That very vague one went away. Remember that the occult is not going to affect outer retina, so that means that just my classic is showing on the last slab. Okay, so that's a really nice way of kind of moving through the pieces and looking at the CNV. This is what it would look like in color. If you recall the last piece, the piece that remained at the end was that yellow piece. That was my classic, and the green was the occult, the one that was underneath it. Here's an example of a patient that you can't really tell what's going on. There's hemorrhaging, there's mottling, there's drusen, and you can't tell what type of CNV this is. You send the patient for a fluorescein. Remember, occult CNV is not going to image very nicely with just a fluorescein. If you look at the early stage, you can see that there's a hyperfluorescent bulb there. That would be really kind of pathognomonic of a classic. It's clean, it's nice, it's well delineated. When we get into the late stages, you can see there's a messy area of stain, which I'm going to say in this particular instance is an occult membrane. And then you can still see that yellow clear piece on the side, which is our classic one. What if you weren't sure, though? Because remember, occult is messy. What if that's something else? Who knows what that is? So we do an OCTA. Let's first look at the B scan. If you look at my dotted red line there, you can see that that's the RPE. The RPE is separating my 2 CNVs. I have the sub-RPE with the red arrow. That's my occult. And then I have the one above the RPE, the yellow arrow, is my classic, okay? What does the angio look like? We start off at the level of the choroid again. They should both be at the level of the choroid. They both originate at the level of the choroid. What happens, though, as I move my slab more anterior? My occult membrane is beginning to disappear because, remember, it doesn't go up to RPE. So only the classic should stay the same concentric shape. The occult is going to begin to disappear. RAP is tricky. I'm going to talk about it just because I think it's important to include in the conversation, but RAP is not always the easiest to diagnose. So Unlike our other CNVs that originate in the choroid, RAP originates in the deep retina. Okay, so when you look at these pictures, you can see the picture on the left, which is stage 1, shows that little cluster of red vessels. That's the angiogenesis. That's starting in the deep retina, okay? So in this particular type of CNV, it's an intraretinal problem. Sometimes they originate in the choroid, but for purposes of this conversation, we're going to talk about it in the retina, okay? This is the stage where the patient will present with hemorrhaging, edema, okay? But you can't really tell. Anybody can present with hemorrhaging and edema. As we enter into stage 2, the angiogenesis, instead of coming up from the choroid, is now moving posterior. So it's starting in the deep retina, and now it's coursing down to the RPE. It doesn't break through RPE yet. It's subretinal, but it's coursing posterior. This is where you start to get the serous detachments, the serous PEDs. When you get into stage 3, the membrane has now permeated through the RPE. This is where you start to see the bloody component. Okay, once you're through RPE into the choroid has the ability to invade and cause all the damage, and this is where you start to see the fibrovascular PEDs. So when you're looking at the angio, you can see here that there's curvy linear vessels. This is at the level of the deep retina, at least the picture's on the side, because that's really where the abnormal vasculature originates. But remember, RAP is difficult, not the easiest to diagnose. Let's look at an example here. This is an 89-year-old female. If you look at her fundus photography, you cannot tell with certainty what's going on. They all look the same. There's bleeding, there's hemorrhage, all this good stuff. Look at the scan though, okay? The scan is showing us a serous PED. It's showing us neurosensory detachment, and then above the level of the PED is the crucial piece. There's that hyperreflective bulb right above the level of the PED. That's that angiogenesis. That's that little tuft of abnormal vessels that I showed you on stage 1 in the first slide, okay? So just by looking at that B scan, you could probably tell that this is RAP, but let's say we wanted to be sure. You can see on the fluoresceins that something's beginning to stain, okay, especially towards the late phase. If you look at our angio, the outer retina, again, is the critical part because that's where the vessels originate. That is the point or the source of insult. And these vessels with RAP tend to highlight like a Christmas tree. They're very small and they're very, very bright. One more example here, 84-year-old Hispanic female. This one is an even better example because here, the fluorescein showed us nothing. The hemorrhaging was blocking all of the whatever you want to call it, the dye. We couldn't see anything. So this is a great example of where the angio really comes into play because the leakage isn't going to bother the angio. Okay, so here, look at the B scan. Here, the PED looks more fibrovascular. It's not serous anymore, so this one's probably a stage 3. This one's crossed over the line, but look at that critical point again. Right above the PED is that hyperreflective bulb. You see that? That's the angiogenesis. That's the abnormal vasculature. When you look at the B scan, the blue line is running through the RPE. That's where my cut is on the angiography. Look at the highlighted bulb at the level of the deep retina. Pathognomonic for RAP. CSR, in the normal ones, the easy ones that we see every day, CSR will look like this kind of black mess, if you want to say. It's a blockage because there's fluid there. Okay, so you can't see the vasculature because it's blocked. But the B scan is clean. You can see there's neurosensory detachment. There's nothing to worry about. But remember, when CSR lingers and doesn't want to go away, it becomes dangerous. All right, so here's a patient. You look at fundus exam. It looks like a big blister, but if you look at it, you can see there's a yellow area that looks a little funny, kind of superior temporal to the fovea. Look at the B scan. Doesn't look as clean as the previous patient. You can see that this neurosensory detachment's irregular, and you can see there's a lot of almost hyperreflectivity on the side of that serous detachment. So this would definitely be a suspicious slide, but now we can actually use OCTA to help us to make a better decision. The fluorescein confirms that there's something going on, okay? But the OCTA solidifies it, okay? So look at the choroid. Remember, occult CNV is usually associated with chronic CSR and PED. Remember that occult CNV is messy and large and doesn't usually affect the foveally vascular zone. Look how pretty that is. That's a perfect occult membrane. The outer retina has some projection artifact because this is an old scan, but the outer retina is not affected. So it would confirm the diagnosis that this is an occult CNV associated with chronic CSR. What about PED? PED, I think, is probably, if I have to say, the thing that I'm using this, I think you said before you're using for diabetes the most. I think PED is where I use it the most. I see patients like this all the time. This patient was a patient of mine I've been seeing for years. He's got dry AMD, but there was a funny little spot there. See the pinkish orange spot there next to the fovea? I said, let's get some B scans. We do the B scans, he's got lots of drusenoid PEDs, okay? But the concern was on the scan, there's a little serous pocket of fluid there above one of the drusenoid PEDs. Whenever you see serous fluid associated with PED, you worry that there might be CNV, right? So if I didn't have OCTA, this patient anyway is you need to go get an ICG or whatever, buy. My patients have no insurance, it's a disaster for them, so they come back a month later and they're a mess, which wouldn't have changed, but look at the OCTA. So you can see on the top there, the fluorescein, again, if it's occult, not gonna really pick up nicely. It doesn't really show me very much. I don't know if you can appreciate on the ICG that there's a kind of like a linear area of leakage there. But if you look at the OCTA, you can see it's starting, it's a baby. But look at that abnormal little vasculature, there's a little net beginning to form. Okay, so this was just the beginning, but what a great catch and what a great save for the patient. This patient actually did go see the retina specialist, doing very well. And I want to kind of end with on this note, because I love this slide, because these are both my patients. And I thought these both looked suspicious. I know I should have made the B scans a little bit bigger, but in A, lots of drusenoid PED, and it's not really magnified, but if you were to look at it really closely, it looked like the one I just showed you. There was a few little serous pockets around that really big drusenoid PED in the center. And then the one on the bottom also looked kind of funny. There was a lot of irregularity. Again, a serous pocket. I would have referred both of these out. I'm going to be completely honest, because they both did not look clean enough to me. These are the B scans I was talking about at the beginning. And then I did angio on both of them. The guy on top, A, who I thought looked worse, was actually fine. And the guy on the bottom, if you can see, he had a little baby neck going on there. If you can appreciate that with my red arrow. And he also was treated. So when I show this slide, when I do this lecture, this is like the ODs look at it and they're like, wow, how much have I missed over the years, right? It's like, this is crazy. We see these every single day. And I certainly was not as aware now then as I am now about how much we're missing, how much we're not seeing. So that concludes my part of the presentation. I think, Nate, you're going next on diabetes. Thank you for your attention.